Good afternoon, everyone. Welcome to this DTAC webinar. This is part of our Documentation Best Practices series, and today's webinar is Treatment Plans. Today's webinar will be presented by myself, Brianna O'Connor, and Dave Eckert.
Hello.
We will just do a couple of quick intro slides like we usually do for folks who might be joining us for the first time. This presentation is put forth by the Managed Care Technical Assistance Center, which is made up of the McSilver Institute for Poverty Policy and Research, as well as CASA. There are a number of partners of MCTAC that also participate in this work, and as you can see, their graphics are listed there for you, and Dave and myself are from CCSI. The team that put this presentation, and in fact the full series together, really consists of a wide variety of individuals from all sorts of different service areas. So Dave and I are both currently or recently both providers and supervisors, so we bring that expertise to the table. But we also have folks with expertise in other OMH services, OASAS, residential, home and community-based, peer and family support. So there's really a diverse group of folks who put their thoughts into these presentations to make sure that we're as widely applicable as possible. One of our partners is also representatives from several New York State serving managed care organizations. So as we're developing these materials and coming up with what these best practices are, they're based not only on available research, our own experiences and best practice ideas, but also conversations with those MCO representatives about what they're seeing currently in records and what they would ideally like to see moving forward to make a more successful communication relationship through documentation. This series overall is a 6-part series. We are currently in webinar 3 of 6. We're looking at treatment plans today. The previous 2 webinars are available on the MCTAC website, so if you missed them or want to revisit them, they're there for you. Likewise, this presentation and all of the others will also be up for you to review both the recording and the webinar PowerPoint slides themselves. So you will be able to access those later. We are going to ask you to fill out just a couple of quick poll questions in a moment before and at the end of this webinar, so we can get a sense for how good we're doing at reaching our objectives and if we're hitting the mark and getting across what we think we would like to. We may also be contacting you at the end of this entire series to see in general if this series was helpful to you. As usual, your feedback for MCTAC is incredibly important because it helps us know where we might need to provide future offerings in the future to meet the needs of you. If you have any questions at any time during this webinar, please feel free to chat them in the chat box. And you can also email the MCTAC help desk, and they will circle them back to the appropriate folks. One final disclaimer before we get started. Information today and in this series overall reflects general best practices. Our goal is to make sure that these are best practices that are foundational for all types of documentation across service areas. Again, whether that's OMH, OASAS, residential, community-based, these are best practices that should be reflective of good practices in all of those different areas. But that information is also current right now to the best of our ability as of today, December 14th, 2016. While we have done our very best to make sure that none of the information that we present conflicts with any regulatory requirements, we do want to note that what we're presenting may not be sufficient to be fully in compliance with your various regulations and requirements. So you do want to make sure that you're double checking those and not using these as the be-all end-all of documentation. Finally, information presented in this series and today's webinar specifically does not reflect the official guidelines specific to any particular managed care organization. A quick plug for our next webinar. In January, we'll be back with the next in our series, which is a whole webinar devoted to the progress note and how to make sure that that's an effective piece of documentation as part of your documentation suite, and that will be on January 11th. And at this time, we'd like to pull up, there are a few poll questions that we would like you to respond to. They're on the right side of your screen right now. These are, again, just really quick questions that will help us understand who you are so we know who our audience is when we're thinking about putting together some of this content. And also right now where you are at before we begin on your understanding of the differences between treatment goals, objectives, and interventions, as well as your understanding of how to write effective treatment plan objectives specifically. Those are two of the areas that we hope to provide you with some pretty strong guidance today. We'll wait just a few seconds and let folks answer those questions. Looks like people are answering, so we don't want to cut it off too soon. We appreciate your response. Definitely helps us in our planning efforts and making sure that what we're providing is helpful to you and that we're reaching the correct audience with what we think we are providing. So we'll wrap this up in maybe 10 more seconds. So if you are working on answering or thinking about answering, if you have a few more seconds to please do so. All right, and we're going to go ahead and close that poll. And at this time, I'm going to turn it over to Dave Eckert to kick off the content.
All right, great, thank you. Glad to be here with you this afternoon and to be doing this part of our series that helps with documentation. So the objectives of today's webinar. The objectives of today's webinar, not to be confused with treatment plan objectives, but today's objectives are to review the documentation leading up to treatment plans. We are going to talk again to revisit the concept of medical necessity and establishing the need for treatment. That was the webinar that came before this, but that's very foundational to what we'll talk about with treatment plans. Essential to all of this, too, is the concept of the golden thread and what that means in quality clinical documentation, and that link from assessment and defined needs. What does the person need? What are they? What should they be getting from us? And how we identify that in assessment as the springboard for the treatment plan. And we're going to focus a lot on the essential elements of effective treatment plans. It's important to note that there's no one way to write a treatment plan. And we are depending on the work of Adams and Greeter here in their book, Treatment Planning for Person-Centered Care, Shared Decision-Making for Whole Health. It's an excellent text. Again, just like there's no one way to write a novel, there's no one way to write a treatment plan, but they've offered us some excellent guidance here on how to do it, and we highly recommend that text. They describe and will be describing the difference between goals, objectives, and interventions in treatment plans, and we're going to provide some examples that we've come up with. Again, these are just examples. They're not meant to be all inclusive, but are meant to kind of show how we put these elements into practice. So the previous webinars in our series, we've had best practice documentation tips from the managed care organizations. That covered the importance of quality clinical documentation, red flags or problem areas in documentation, common problem areas that we've seen, and some advice on do's and don'ts of documentation in general. And the second webinar, which builds up to this one, so if you haven't seen it, it might be helpful for you to do that, relates to the foundations of effective documentation and establishing the need for treatment. This relates to medical necessity, again, these key themes, the golden thread that runs through assessments and treatment plans, and our next series on progress notes. And again, we'll be using the assessment material as the springboard for effective treatment planning and talking about that again. So everything we do, we want it to be grounded in person-centered practice. We want the person receiving services to lead the way, and we follow, we work with them in a shared decision-making capacity to help them get their needs met regardless of the level of care or type of services being provided. As Brianna was saying, we work with many different types of providers, from residential to outpatient, et cetera. There's a vast array, but everything should be grounded in person-centered practice, where the individual is the expert in their life. We've identified their strengths, capabilities, interests, preferences, needs, hopes, and dreams. We are culturally and linguistically competent, meaning we are literally speaking their language and understanding their culture as we work with them. And because recovery happens in a social context, we want to involve significant others and key collaterals as appropriate. A good rule of thumb is if they're getting mentioned in session, they should probably be in session. We want these individuals to have their supports tied into the work we do with them. And a person-centered practice is also a systematic way to align what we do with what the person wants and needs. And that can be broken out to the do's and don'ts of person-centered practice. So what we do is we put them in the driver's seat. We put them in control and let them lead the way. And we don't forget to include them in recovery and those that care about them. Again, recovery happens in a social context, so we want those folks involved. And supervisors especially can support this as well by understanding person-centered practice and reinforcing these expectations as part of all service delivery. So, medical necessity, moving on to this important theme, the cornerstone of medical necessity and of effective treatment is in proving that the treatment is necessary from a medical standpoint, and it's first delivered by an appropriately qualified practitioner, appropriately licensed to deliver that service, and clinically appropriate services are delivered by this person. They focus on why the service is needed to address symptoms that impact daily life functioning. So the diagnosis is the cornerstone of medical necessity. We have to have a diagnosis to proceed with treatment, but the symptoms that support that diagnosis are what we focus on, and the elements that get in the person's way related to those symptoms, the barriers, need to be paid attention to. We want to make sure we're delivering services at an appropriate intensity and duration. We don't want to underdo it. We don't want to overdo it. We want to meet their needs and deliver services that have that intensity and duration to meet those needs. We describe these in the individualized treatment plan, and we really want to emphasize that word individualized. We want it to be person-centered. Cookie cutter and cut and paste treatment plans are part of the don'ts that we've talked about here. So we want it to really reflect the person's voice, their needs, their desires, what they want to see come from treatment, regardless of the program that's serving them. Of course, we want it to improve their functioning and reduce symptoms or prevent worsening of symptoms. It can be medically necessary to help a person maintain their gains, and we want our documentation to reflect that. And again, the cornerstone here, it's based on an approved diagnosis and assessed needs. Examples of medical necessity and documentation, again, it's the appropriately qualified practitioner, and we see an array of those here, from psychiatrists, nurse practitioners, CASACs, social workers, licensed mental health counselors, etc. They're appropriately credentialed and qualified to deliver that service. The approved diagnosis, in this example, major depression is used, and it's supported by symptoms. Frequently with major depression, we see sleep disturbance, lethargy, sadness, memory impairment, lack of enjoyment, etc. These are the symptoms we want to target and reduce to reduce the impact of major depression on the person's life. The assessed need, in this case, this example, the depression is causing problems in relationships and the client is unable to hold a job. The intensity and duration, well, we've compared this with the criteria in the DSM-5, and we've noted that it's moderate to severe depression that's been lasting about 3 months. And we will find that would be an approved diagnosis and a reasonable need for treatment. Treatment plan goal, now here's where the person's voice would come out. I want to feel like myself again and get back to work. not an uncommon expectation for what someone might say who's struggling with depression and really wants to get their life back. So the golden thread, this is a key concept. It means that the assessment information, the established need for treatment built on the diagnosis, the person's strengths, their goals for treatment, and what they need is reflected in the service plan. Frequently, the analysis and formulation, that end summary statement at the end of an assessment, acts as the springboard for a service plan. It establishes the need for treatment. That's what the assessment information should include. And the plan then picks it up from there. What are the person's goals? What is their quote about what they want from the service? And how would we restate that so that we can make that in medically necessary and definable terms? How do we define the objectives, those rungs of the ladder of those steps on the way to recovery? And how do we define what we will do, what we're prescribing, those interventions and the services that we will offer to help them achieve their treatment objectives and work toward discharge? See how all of these things tie together and are documented then, and this is our next series, next presentation in this series related to progress notes. So we're literally following the golden thread as we go through this series of webinars here. And the progress notes should then tie back to the service plan, and the service plan again ties back to the assessment. So there should be clear continuity backward and forward as we review the clinical documentation. Okay. Analysis and formulation, the discharge criteria. So as the springboard for the treatment plan, the analysis and formulation is the statement that summarizes what is the need for treatment and how will we be delivering that treatment. So in this case, the client's discharge criteria is the client will be effectively managing the symptoms of depression for 3 consecutive months. Now, that's a reasonable measure that shows us that would be based on client self-report as to their view of their management of depression. An even more definable way to do this would be that the client would score a 16 or lower on Beck's depression inventory for 3 consecutive months. So we could use an evidence-based tool to measure recovery. And the plan for treatment then that could come out of this. Also, let me pause to say, notice how we begin with the end in mind. So as we're assessing, we're also noting this is the end, this is the result of treatment. We're taking kind of a treat-to-target approach, the way they do in medicine, that this is when we'll know when we'll be done. Really helpful from a therapeutic perspective to define that for people. It instills hope and kind of lets them know there will be an end to this. There is a time when you won't need us anymore when you've achieved this. And then we go to the plan for treatment. In this case, we're using cognitive behavioral therapy to address the relationship between thought process, behavior, and mood, and help the person understand how these go together and what they can do about it. Medication evaluation may be helpful to determine if psychotropic medication could assist them, looking at possible SSRIs or some other medication, and also to involve the person's relationship, the people they have relationships with, and to do couple sessions to enhance emotional support system and to reduce conflict at home that may be related to irritability with depression in this case. So developing treatment plan, goals, objectives, and interventions. I'll turn it over to Brianna now, who will talk specifically about these elements of the treatment plan.
Thank you, Dave. So first we want to talk about the differences between some of these things, and all of these are collectively referred to as treatment plans. And a couple of key elements about treatment plans. So these are very often, if not in almost all services, required. There are often time frames that are tied to them, so you might be familiar with treatment plans that need to be written or revised or documented that they were reviewed every 3 or 6 months, for example. But it's also important to remember that a treatment plan, in the sense of that it's a recovery roadmap, is also fluid and should be revised as needed. I'm sure we all have learned this lesson as providers or supervisors that we don't know everything at day one, and so certainly the ability to revise that treatment plan to reflect when we do have new knowledge or new ideas about what would work best in this situation to help this person along their recovery journey is really critical. The treatment plan also serves as that sort of roadmap, that plan or the anticipated course for how things are going to go. But again, once it's in place, it can certainly be revised to reflect that there might be alternative routes or alternative strategies that need to be tried, unanticipated barriers that have come up that need to be addressed before more progress can be made. As Dave mentioned, treatment plans also, from the outset, start to identify that criteria for transition to a lower level of care and discharge. And they really reflect this kind of agreed upon destination, and destination really here being just carrying through our roadmap analogy, because we do know that it's not about an end point where anything would be symptom-free necessarily. It's really about recovery and where is the end of this particular episode of care going to be and what's that going to look like. High-quality treatment plans also are sure to integrate all aspects of an individual, so their physical and behavioral health, some of the social determinants of health and their social factors, natural supports and resources, and it's really far more complex than an A to B. We started here, we're going to get there. The elements of a treatment plan, again, as far as we're talking about today, particularly as Dave mentioned, following the Adams and Greeter text that I believe is in your chat box with more information, really thinking about the treatment plan as consisting of goals, objectives, and interventions. These are obviously very related concepts, but they really should be distinct. And when they are not distinct or when they start to overlap, it can really start to cause some issues in the course of treatment or in the course of care, because it contributes to confusion about progress. It might be the reason that treatment sometimes plateaus or it gets kind of stagnant because it's not clear what we're working on and how we're getting there. And it might contribute to some of those feelings of spinning your wheels if these things are overlapping. So that's why we wanted to spend some time really talking about them distinctly and what their distinct role on a treatment plan is. So first up is the treatment plan goals, and these are those big picture goals that are directly correlated to a particular problem statement or functional deficit. Functional deficit can also refer to an area of impairment or an area of daily living where there's some negative impact for this individual. That's what I mean by functional deficit. But really, treatment plan goals tie specifically to one of those areas of a problem for an individual or an area they'd like to address, and speaks to how it can be reduced or resolved. Treatment plan goals are very global, they're very broad, they're often best stated in the individual's own words, and they really address what that person would like in their own lives and what they would like to see changed. Treatment plan goals need to be written strengths-based, as Dave mentioned, and the person-centered strength-based approach really should reflect the individuals and families, their own strengths, their resources, their motivation for pursuing this process. Treatment plan goals are also often the long-term picture. They indicate what, again, the end point of the episode of care would be, and again, not implying that the end point is a symptom-free existence, but it's the end point of what this particular episode of care is going to address. Also, there are often very many treatment plan goals, so like many of us have our own goals, and there's more than one of them at any given time, and so that's often the case as well in treatment. And so goals often need to be prioritized, ordered, sequenced in a way that makes sense. And we'll talk a little bit about some best practices for sequencing them in a few minutes, but also identifying that there are certain goals that folks have that might not be addressed by this particular service, and so prioritizing what can be addressed by this service at this time is certainly helpful. Here's just an example of how to reflect something in someone's own words. There might be a big picture life goal, we'll call it, so I want to be married again, is a life goal that person might come in with, but the process really is how to use some finesse to sort of refine this into language that applies more particularly to this treatment setting and to this, into medical necessity, as Dave mentioned, to really get at how is this service going to help this medically necessary goal. So in the life goal of I want to be married again, where that could be shuffled into a little bit more clear of a treatment goal would be I want to return to live with my family. And then in this setting, how we can address that goal, how we can refine that goal might be, I want to get sober so I can be a better parent and spouse. And that treatment goal is much more specifically tied to this setting and to a medically necessary kind of billable service. A similar example for perhaps maybe this is something that I might have heard from a younger person, you know, the life goal is I want to be rich and famous. But what does that mean to that individual in this setting? Well, it could mean that I want to be successful in my career. How are we going to help you get there with this treatment in this setting? I want to graduate on time and get into college. That's a much more concrete kind of goal with a big picture focus, still very global, still in the individual's own words, but helps refine what we'll be helping that person accomplish. In contrast to those global, big picture, long-term treatment goals, treatment plan objectives really focus on what the specifics are of what needs to change to meet said goals. So in order to be successful at the goal, we often think that, you know, if an individual could be successful at their life goals and their treatment goals, then they wouldn't be here, they wouldn't need us. And so really the key here is to identify what are the barriers and challenges to achieving that goal that we can identify and that need to be addressed. One way to think about that is to conceptualize these barriers as perhaps a lack of resources, and this can look in a lot of different ways. It could be a lack of psychological resources, and so that would be where some of those symptoms might come into play, having excessive fear and anxiety, confused thinking, irritability, poor anger, impulse control are all perhaps representative of psychological aspects that can reflect a lack of resources to meet some of the goals, as we mentioned before. Similarly, some psychosocial resources that an individual might struggle with, being uncomfortable around others, being socially isolated, having difficult or not many supportive relationships, really struggling in their daily functioning, accomplishing day-to-day tasks. And there's also physical and medical resources that an individual might identify as barriers or challenges to reaching their life goal and their treatment goals. And just some examples listed there. In terms of those social determinants, housing, nutrition, health, transportation, continued drug use, those things can all be identified as barriers that can be translated from a goal into an objective. One acronym that we'll be walking through for a few slides here to help kind of focus a treatment plan objective and how to write a solid one would be our RUMBA acronym, and that stands for Realistic, Understandable, Measurable, Behavioral, and Achievable. There are certainly others. This is one example, again, that we sort of like because it speaks to sort of the high areas, hits the high points of what we have collectively come up with as some of the better ideas, but there's certainly others. The first feature of an effective treatment plan objective is that they are realistic. So really thinking about what is being worked on right now in this setting. These should be, the objectives should be tied, again, to those individualized treatment goals, the individuals presenting symptoms, their current functioning, and where they'd like to go. Objectives also should be reflective of the individual, their age, their development, and their culture, and the culture in which they reside. So as one example, for a young single mother from a family-centric culture, if her goal is, I want to be independent, in her own words, one objective that could be written is that she establishes her own apartment. However, then that raises the question, is that all that realistic? Is that appropriate in her culture and her understanding of her culture and her family dynamic? Does she have is she in the right circumstances? Is that realistic to ask that she might do that with her available resources and supports? And so that objective might be better revised to reflect some of those more individualistic, realistic features. So a better way to say that goal, that objective might be to that she will take over her child's evening routine from her own mother, including bath, bedtime activities, and discipline as needed. So she's beginning kind of in a small step to become independent in terms of taking care of her child, but we're not discounting or overruling the fact that her culture and her family dynamic is a really critical part of who she is. The next letter in our acronym is that treatment objectives are understandable. Here it's important that objectives are stated so that everyone knows what is being worked on. What is the goal? What is the objective? What are we doing? Here we want to use clear, non-jargon wording. So if the person who's receiving care, so the member, the provider, any key collaterals, any family members or social supports that are part of this treatment team, and the supervisor of this provider should all be able to easily understand and describe the treatment objectives. This becomes challenging if the treatment plan is written and put in the documentation in the electronic health record and never referenced again. It can really contribute to, treatment kind of veering off course and getting distracted by the crisis of the week. So making sure that everyone's clear about what we're working on and what that objective is can be really important. Putting it in the person's own words also really helps to reinforce it for them and to really make sure that they understand what it is that treatment is addressing. For example, a perfectly appropriate objective to some might be that the member will restore mood stability on most days. However, a better way to state that for an individual who maybe doesn't speak that language and doesn't think in terms of mood stability would be to be a little bit more concrete and use maybe her own words and say that the member will report feeling in control of her emotions at least 4 days per week, and there we can say we'll rate it on a scale of 1 to 10. She'll just tell us 1 to 10 every day, does she feel in control of her own emotions. One area to be careful of here, I know in my own work I've worked with children, and sometimes they might come up with their own kind of name for something. So what we would want to avoid in a treatment plan would be saying, that the child will report feeling in control of worry Walter, if that's what he calls his anxiety, because that's not going to be clear to anyone else reading the documentation what it is we're referring to. So you can certainly include that in the documentation, but in the treatment plan you want to be clear about what that means, and that might mean, here again, feeling in control of his or her emotions. Next, it's also critical that treatment plan objectives are written in a way that is measurable, because that's how we'll know when we've reached this objective, when it's been accomplished. Where possible, using concrete data is preferred. It's easiest for everyone. Members like to see, charts or data that show that they're getting better in certain areas or making progress in certain areas. It's easier for you as a provider and supervisor to have a relationship or have a discussion about that relationship if there are some numbers to work on instead of anecdotes. So really we recommend data. What that looks like, though, doesn't have to be necessarily overwhelming. As Dave mentioned, there certainly are a number of evidence-based assessment tools that can be used for various symptoms and areas of functioning. There's certainly validated questionnaires that might get at some of those things. There's also behavioral data, so collecting some food diaries or point system logs can be data that can help you identify whether you've reached that objective. And then it can also be as simple and intuitive as the 1 to 10 scale I mentioned previously, where it's really just asking the same question on a scale of 1 to 10 of that person regularly to understand what their perspective is on how they're progressing.
And I just want to jump in here to say that the 10 should always be what the problem looks like when it gets better. And having reviewed a lot of documentation, sometimes the 10 is set up as depression at its worst. We don't want to aim people looking at down the road toward a problem that's getting worse. So how we frame that is very important. So 10 in this case would be the opposite of depression and what it looks like when mood is being controlled. So I just want to interject with that.
Sure. Great clarification, thank you. In thinking about measurable objectives, really thinking about making sure that, as Dave mentioned, that it's clear what the goal is or what progress would look like. So if you think about a fly on the wall, if everyone on this webinar right now got the same data about the same objective from the same individual, we would all say yes or no the same way about whether that objective has been met if the right measurable data is being collected or the right measure is happening. Anecdotes and talking about the person just in general feeling better are certainly important clinically, and we want to know those things, and it's great to know that they're feeling better, but they're really not sufficient in documentation because that can look very different for different people. So writing these objectives in a way that is more measurable is really important. So for an example, member will be less aggressive at home is not quite as measurable as member will reduce instances of yelling at domestic partner 20% in the next 6 weeks, daily average going from 10 to 8. Those kinds of concrete numbers, again, if we all had the same data for this objective, we would all come up with a yes, no, whether or not the member reached that objective. And that's really what a truly measurable objective might look like. Objectives should also be very behavioral. Again, some of these overlap in their concepts, obviously. So if you're writing a measurable objective, it's generally fairly behavioral. But really what this is getting at is, what will you see as the work is being done on this objective? What will the individual or family do differently? And it's really important that these are also action-oriented language. So historically, we might have thought of things like gaining insight, better understanding themselves, coming to accept this new role. But those really aren't action-oriented and don't give us something to measure and quantify and look at. So thinking about, instead, those are great ideas. You want them to be able to gain insight. However, what are they going to do differently, or what are we going to see that is different because they've gained that insight? As an example, Lucy will acclimate to her new role in this program. What that means, what acclimating looks like, how I know when she has acclimated is not clear from this objective. So instead, an alternative might be that Lucy will respond appropriately to social interactions at least 20% of the time, most days, with one or few reminders from staff. That example is more clear, it's more specific, but it's actually one that I would say is probably, as I'm reading it, you might have thought, well, that sounds hard, how will we know, how will we track that? So this is on here as an example of, actually sometimes you can overdo it. So it's possible to over-measure your objective. And so really thinking about how are you going to know that you've accomplished it without having to, do complex math calculations and memorize, what happened 20 minutes ago and yesterday. And so perhaps a better objective might be that Lucy will participate at least once in 4 out of 5 recreation activities per day. And that is reflective of Lucy acclimating to her new role in this program, but is a lot easier to capture and quantify as a frontline provider. The final letter in our acronym is that treatment objectives need to be achievable. So here's it's important to think about what are those early successes or short-term wins that we're targeting. We do know that early success predicts later success, so thinking about short time frames where objectives might build on one another sequentially, we know that that can build optimism within the therapeutic relationship. It can build a sense of self-determination in the individual and really pick up that treatment momentum and keep things moving. If it takes 6 months before we've looked at the objective to see how are we doing on this, A, you might have lost 6 months of time if you realize that that's not the best objective for this individual, and B, there's not a lot of concrete feedback to say, hey, look, you're making success, you're making steps, and so really thinking about shorter term periods of time and achievable goals. For example, Ted, who's recently living independently, is hoping to get a job. That is his goal, that's his treatment goal, but we know, especially for employment, that can be a lengthy process, and it's also not always up to him. It sometimes has to do with the job market and what's available. And so we wouldn't want to say that treatment's not being successful just because he hasn't necessarily gotten a job. So we really want to document those achievements, those milestones on the way to reaching that goal. So we might have identified barriers for Ted that include lack of transportation. He doesn't have his own transportation, and he's got a fear of using public transportation. So to identify an objective there, we might say that within 30 days, Ted will be able to take the bus from his home to downtown and return by himself. And that reflects a very achievable short-term milestone that we can identify as a successful win that's on the way to moving Ted towards getting a job and being able to successfully get to and from his job. A final kind of way to think about objectives and a do's and don'ts framework here is to think about the fact that you do want to have objectives that reflect those achievable steps, and you don't want to confuse objectives with interventions, which we'll talk about in a moment. So often we'll think of getting a great job as what you need to do to get a great job is enter this job skills training program. But really, we all know that there are quite a lot of steps in between that could reflect those achievable steps instead of just yes, no, are we getting a job? And you'll see this example here doesn't even end at getting a job because we need a much bigger screen because there's a lot more steps that happen in between. And these are all opportunities to identify an objective and monitor progress and measure success for that individual and for this process. The final piece of the treatment plan is treatment interventions. So these are the specific activities that are helping the individual to achieve their goals and objectives. Another term for treatment interventions might be the actual treatment, the care, the services, the support, medications are an intervention, the program they're attending is an intervention. And these are distinct from objectives, where objectives are those desired changes, what they want to have happen. The interventions are the steps actually taken by the team to bring about those changes. And the team here can refer to the treatment team, the support team. It can include self-directed actions by the individual, natural support. So it's a broad definition of treatment team or of team, but really the difference is objectives are what you want to happen, and interventions are what's going to make that happen. They're really the methods for achieving the goals and objectives. In our roadmap car analogy, these would be the resources and equipment needed to support the journey. So the journey is still laid out in the goals and objectives. This is what you need to get there. And with that, I will turn it back over to Dave to walk us through some additional examples. Oh, actually, I will say one more thing, and then I will turn it over to Dave. This is just a quick example, again, one example of many of how to describe intervention, so using the 5 W's of what, who, when, where, and why when talking about the intervention. What is the service? Who is responsible for completing that particular activity? Again, if it's a natural support, you want to clarify that in your treatment plan as well. When will this occur, this activity occur, and what frequency and duration? Where, if it's appropriate, where is this intervention going to take place? And then why? What's the purpose of this particular intervention in support of that objective? This is just one example, again, of writing interventions in a little more tight way. Now I'll turn it over to Dave.
All right, thank you. So tying it all together, putting this all together, again, we're going to talk about some examples here, but it's just impossible in this amount of time to cover examples that cover all program types. So we're providing examples that hopefully have some nice generalizability to your work with whatever program you're in. And I want to start by emphasizing, too, that it's all about collaboration. It's the individual receiving services. It's their plan. So everything would start with them and reflect their words, their desires, et cetera. It's important to restate that. So as we've developed these examples, I really want to impress that these would be developed with the person you're working with. So going back to some examples we used in establishing the need for treatment, we're going to build right off of those to link then into planning and how we plan for them. So in this example, we have a 52-year-old Hispanic female, symptomatic for 2 months, with depression, and has a family history of depression as well. Again, also, these are succinct slides. There's no way we could capture all the information that you'd see in an analysis and formulation. But these are the questions we'd have answered to establish the need for treatment. We'd also want to make sure they're not at risk, and the statement here is she's not suicidal. She would say, I feel sad most of the time and I don't really enjoy anything anymore. We'd also want to know what are the symptoms, but how do these symptoms become barriers? What does the person need to overcome? What do they want to overcome? Well, they have trouble sleeping, lack of appetite, low energy, crying spells, interfering with relationships, and client is missing work related to depression. What does the client need to successfully overcome these barriers? Supportive care, CBT is an evidence-based practice for use with depression, and possibly antidepressant medication, and the assumption would be that your agency provides those services. Why would these services be most helpful? Well, CBT, again, it's an evidence-based protocol. Research shows it can be very effective in treating depression, especially in combination with medication. And we are using the springboard of the person's quote. It's their plan, I want to get my life back again. So in our example of treatment planning for depression, we begin with I want to get my life back again. We would want to state that in clearly more clinical terms, as Brianne covered in her examples. So what would that look like? Client would be effectively managing symptoms of depression for 3 consecutive months. We talked about those scales from 1 to 10. If 10 were effective management of depression and 7 were, you know, it's not perfect, but it's good, because again, we don't see symptoms completely remit, but we do see them decrease to a subclinical level where they're not debilitating, they're not disabling anymore, and they're considered manageable. That is often the goal of treatment. We don't achieve perfection, we achieve improvement. But another way to quantify this would be using Beck's depression inventory, and a 16 or lower indicates that subclinical level. Now, looking at the objectives, and we're writing these with RUMBA criteria, these would also be typical objectives that one could use at the beginning of therapy. Again, I want to emphasize that these would be written with the person. There's nothing cookie cutter about this, so these are just examples, but you would want to work with whoever it is you're partnering with the client to develop these objectives. But here's some example. The client will identify 3 coping behaviors that she can use when she is feeling sad. Pretty straightforward, easy to understand for all parties. Hopefully very achievable, and hopefully time limited as well. Client will join a gym and will participate in an aerobics class once a week. So this would come out of a person-centered goal. The person has to get out and get moving, and we're also aware that that has a very positive impact on depression. Exercise does. And also, client will engage in a social activity with friends once a week. You can see the person-centered nature of these objectives and how clear they are. And they all illustrate what the client will do. Now, the interventions, this is what we're prescribing. These are our methods. This is our vehicle. And we will provide CBT sessions twice a month for the next 3 months. The psychiatrist will complete an evaluation for possible use of psychotropic medications to assist client with the management of symptoms of depression. We see the 5 W's there, the who, what, when, where, and why. It's assumed the where is at the agency. And the primary therapist will provide couples family therapy sessions once a month for the next 3 months. So you're prescribing everything you will do, and it's important to be inclusive and include every intervention that you'll be prescribing, because the treatment plan is your contract for treatment. So another example, post-traumatic stress disorder. And I realize I'm going through these fairly quickly, but you'll get copies of these slides that you can refer back to. So in this case, the person seeking services is an 18-year-old African-American Caribbean male, symptomatic for 3 months after a car accident. Since the car accident, I've been having nightmares and flashbacks. It's gotten so bad I can't go to school anymore. What are the symptoms and how have these symptoms become barriers? Well, with PTSD, we see intrusive thoughts, flashbacks, avoidance, excessive fear, anxiety. Also with trauma, we see avoidance and isolation at home and struggling with concentration, of course. We see those cognitive impacts of trauma as well. So we'd want to address concentration at school and attendance. What does the person need to successfully overcome these barriers? Supportive care, trauma-focused CBT as an evidence-based practice, and possibly medication. Why would these be helpful? Again, TF-CBT is an evidence-based protocol, and it's been shown to be effective for teens that struggle with PTSD. And then we see their quote, the goal, I want to graduate with my class this year. So we start with that. I want to graduate with my class this year. It's a pretty nice, focused goal, and one that we can make a central highlight in our work with this individual. So client will report effective management of the symptoms of PTSD for 3 consecutive months. This is another place where those 1 to 10 scales are very handy, and where we begin with objectives. Client will identify 3 irrational thoughts and 3 replacement thoughts related to the accident, related to the trauma. Very rumba-oriented here, very clear and easy to understand. Another thing that the client will do, objectives are always what the client will do. We'll set up a meeting with her school counselor to discuss a plan to return to school full-time. And also, client may identify 2 friends that can help her catch up on schoolwork that she has missed to ease that return to school. Also, we're noting that given the developmental age of this client, linking with friends and those social supports can be hugely important and that's why they're woven into these objectives. So what will the primary therapist do? Deliver TF-CBT sessions twice a month for the next 3 months. We'll have the psychiatrist complete an evaluation for possible use of psychotropic medications. And also we see that the primary therapist will conduct off-site collateral sessions that will include the client's school support system once a month for the next 3 months. So here we're getting to that where, and we do want to specify where when it's off-site. So that's included in this treatment plan. Our last example here, heroin dependence, 26-year-old female with 2 previous unsuccessful attempts at outpatient treatment in the last 6 months. She also has a seizure disorder. She'll state outpatient isn't working for me and I need something longer term. And due to the symptoms and barriers we see, daily use, severe risk of medical complications due to withdrawal, and client is aware of the dangers of overdosing and how it might affect her medically. What does the person need? Well, medically managed detox followed by residential treatment. So we complete the locator 3 with this person, and it would elicit a level of care that fits here. So this is what we have is medically managed detox, and her goal is I'm ready to do whatever they tell me this time to get clean. And a plan to address this issue of heroin dependence is client will complete medically managed detox program and will be discharged to Oasis residential supports. That would be our goal. And client, again, is agreeing to whatever it takes to get clean. And client will identify 3 triggers for use. We'll share them in group therapy. Very easy to understand and achievable. Identify 3 coping strategies she can use when she's having cravings. And we'll also contact her support system, her NA sponsor, and notify her sponsor of her current plan for recovery. What interventions, what will we do as possible examples to assist this client in meeting these needs? Conduct treatment groups 3 times a week for the next 2 weeks. This is given that medically managed detox is a short time frame and a relatively short length of stay. Complete an evaluation for possible use of psychotropic medications to assist client with the management of symptoms of heroin dependence. And we'll also conduct collateral session, at least 1 session, to include client's NA sponsor to get that support system woven into her plan for recovery. So there's some very brief examples that put all this together and in a logical way link it to the established need for treatment. Now again, these aren't the only ways to write treatment plans, but these are some examples you can build off of. What can supervisors and providers do today to improve documentation practices? Well, we've offered you a checklist here, and a simple way to, in supervision, sit with the folks that you're working with, sit with your staff, and look at plans together and answer these questions together. Are the treatment objectives clear and easy to find in the documentation? Being a fly on the wall to be able to determine whether treatment objectives have been met. Are they easily measurable and achievable? Are they those baby steps, those next steps toward achieving recovery? Often objectives are written as too far-reaching, and we want success to breed success. We want them to be those next rungs on the ladder of recovery. And other examples here. So using this checklist about evidence-based interventions, multiple treatment objectives, how are we sequencing them, and are we doing it in a way that's person-centered and friendly? So we're going to pause here for our poll questions and let you answer our post questions here related to what we've covered so far.
At this time also, if you do have any questions that you have from this webinar, please feel free to send them over to us in the chat box. It looks like we'll have maybe a minute or 2 to get to a couple of quick ones for you. As a reminder, at the end of this series, so our webinar session 6 is entirely devoted to question and answers. It's an office hours type session. So any questions that we don't get to, that we are not able to answer today, we will be able to answer either via email for you on an FAQ on the MCTAC website or in that session on webinar 6. You can also come to webinar 6 with questions, and we will have a panel ready to answer them for you at that time as well. I do see there's quite a few folks still answering our poll questions, which we do appreciate, so that we understand how helpful this might have been or might not have been for you and whether we're meeting a need.
Also, it's important to note that in this hour, it truly is difficult to capture all of the detail that's required in writing effective plans. So let's consider this a process. As Brianna was just saying, the questions and answers and continued opportunity for clarification, I think is very important, so take advantage of that. Also, I'd like to make the obvious point that people get better at writing person-centered treatment plans through practice and through supervisory support. So we're also going to be doing, as part of this webinar series, emphasis on the role of supervisors themselves and really helping promote these solid, effective practices. So stay tuned, and we want to keep offering assistance with that.
I think that brings us nearly to the end of our webinar. We do not seem to have any questions that have been chatted in at this time. We do appreciate you continuing to fill out our survey. We'll leave that open for you. There's a few people that are in the middle of it looks like. So we do want to do one more reminder that our next webinar in this series, talking specifically about the progress note, is January 11th, and it will also be at this time from 12 to 1. And that will be hosted for you by Yvette Kelly, who will provide a lot of great tips and strategies for making an effective progress note. And with that, if there aren't any, it doesn't look like there's any questions coming in for us at this point, please feel free to send them to the MCTAC email list, and we will be happy to answer them, again, via email directly, FAQ, or on webinar 6 when we have our question and answer office hours. We're going to go ahead and close that poll. We appreciate your feedback and your time. We hope this was helpful to you and wish you all a great day. Thank you.